Good evening, everyone. Just to make it fast, our talk today about the endovascular management of ruptured aortic aneurysm here in Egypt, how we can deal with this. Excellent results can now be achieved with an elective open repair in a specialized center with the mortality rate less than 2%. In non-specialized centers, the mortality rate reaches 5 to 8%. In contrast, the emergency open repair for the ruptured aneurysm in a critically ill patient carries a mortality rate of 30 to 65%. The IMPROVE trial was the first trial to compare between the management of ruptured aneurysm surgically and endovascularly. They conclude that compared to the open surgery, endovascular repair of ruptured aortic aneurysm lead better clinical and survival advantages, better quality of life for patients, and saving for healthcare system. This was according to the midterm results from the IMPROVE trial. Although early data from the trial showed no difference between the two stages in terms of mortality and rate of death, by 3 years, it was lower among those treated with EVAR compared with open surgery. Several studies shown that EVAR, especially under local anesthesia, and this is very crucial, reduced the physiological insult of the body as compared to conventional open repair. This led some to consider emergency endovascular aneurysm repair as an alternative to a conventional open repair in selected patients. So what's needed to establish this kind of treatment in your hospital? First, you need a specialized center, can obtain this, an experienced team, and a good inventory. What we mean with the specialized center, that centers perform elective regularly EVAR and TEVAR intervention equipped with a CT, good multi-slide CT with a workstation, equipped cath lab or hybrid OR with IVUS machine and prepared ICU for the patient. The experienced team is the most important thing you have in your hospital. You need an experienced team for early detection, rapid action, and good planning and fast intraoperative time. What I want to stress about the early detection here, I think any patient with acute onset of abdominal or back pain with a hemodynamic instability, rupture should be suspected first until proved otherwise. And this should be learned to our junior doctors very early in their life. The training is a very important thing, and this is the comparison between how simulation training for endovascular repair of ruptured aortic aneurysm give a better outcome regarding the time of the operation and 30-day operative mortality. What we mean by the inventory that you must have everything available here. In Egypt, we cannot establish this yet in each hospital, and this is a very crucial thing to have everything ready for your patient for treatment. So with the help of the company, we think here in Egypt, it's the company-based inventory. We tried this a lot in our practice. 1.5 hours, 2 hours maximally, you find everything from the company with you in the cath lab. Here's some critical consideration we have to consider. The preoperative hemodynamic stability is directly associated with the patient mortality. The preoperative shock is the most serious risk factor affecting survival. The primary goal is achieving a hemodynamic stability to allow perfusion to the vital organs. Maintaining the systolic pressure between 70 and 80 millimeter mercury and avoid aggressive resuscitation and making blood pressure higher than 100 millimeter mercury is crucial. Volume resuscitation should be delayed until control of the bleeding is achieved. Few studies which respectively have focused in a relationship between inter-hospital transfer and the mortality, and they suggested that there's no major aggressiveness during this inter-hospital transfer. And here's some scoring criteria you can rely on just to show you the risk, mortality risk of the patient before the operation. Some operative consideration. Local anesthesia, I think local anesthesia is the most important thing you should rely on. This keeping the patient tamponading, the patient tone, muscle tone, and in local anesthesia you can achieve a rapid groin exposure if you want to do a surgical exposure or percutaneous technique, and you can perform your procedure very safely with local anesthesia and close monitoring from the anesthesia. What about the occlusion balloon? Occlusion balloon has its cones and prongs. In my experience, I used the occlusion balloons a couple of times. It was not that good experience. After using the occlusion balloons, I have many dissections, many flaps. I cannot find my way easily. So after using local anesthesia, I never used the occlusion balloon, and things are going very well. You have to be very simple in your decision, and you have to be very fast in your procedure just to save this patient. We have to know that no types of endoleak is allowed intraoperatively. When you have the angiogram, no types of endoleak is allowed. You have to fix this. Once you see it, you have to fix it intraoperatively. You cannot allow patient to go outside the OR or the cath lab with any type of endoleaks. And sometimes if the patient with a minimal types of type 2 endoleak and is very stable hemodynamically, you can conserve and observe this. What about the most important things? I think the most important thing in the rupture is the post-operative period. This true challenge to you has begun. Unlike the elective endovascular repair, expect a stormy post-operative course, especially when patients have lost a considerable amount of blood in the preoperative period. You can find many things controlling his hemoglobin level, pain, ecchymosis, compartmental syndrome. So expect a very stormy post-operative period. But my advice in this period, never think about reintervention unless there is a serious hemodynamic change. Unless you find your patient with a serious hemodynamic change, never think about the intervention, because you will find many things that make you rapidly go and try to intervene again, but never think about reintervention unless there is a serious hemodynamic change. And always keep in mind, doing this procedure is a life-saving procedure. Do whatever needed, sacrifice whatever needed to sacrifice from the vessel just to keep your patient alive. Thank you.